Hi, my name is James Nelson. I'm an emergency physician interested in physical diagnosis, and I wanted to say a few things about cardiac tamponade. First of all, tamponade is not a binary diagnosis. I know we use it that way, and that's because in medicine we have to have cutoffs. We have to have that for research studies, and we have to have that just for our day-to-day practice. But understand that there is no binary tamponade versus not. There's this continuum where the effusion on a patient starts to have a physiologic impact. And so it's a judgment call among the physicians managing that in terms of, does this need to be drained at all to make the patient improve? And if so, how long can they wait? There are situations in the emergency department where you need it 3 minutes ago. And there are other situations where you can wait to even transfer the patient to somewhere that can do it in the cath lab, which is a little bit better. The next thing I wanted to say is that everything in emergency medicine is so diverse that you need triggers. You need something that triggers you to think of this. And so essentially the trigger for tamponade is there effusion plus any kind of a problem potentially from that effusion? So, I mean, the classic one is hypotension. If you have hypotension and effusion, then you just assume that that is tamponade, and then go through the process of proving that it's from something else and that there's no tamponade. And that should be a process that involves cardiology, but it's not straightforward. Most of the cardiac tamponade cases that I've encountered have not been as clear-cut as we expected early in my career. And the reason for that is because this is one of those classic paradigmatic diagnoses, and those are described in an earlier time in history where diagnosis was not as easy to make, and so diseases would present in later stages. And when they present in later stages, you get these classic findings, but then in real life, in the current era, you're not going to have all those classic findings. Now, the next thing I want to say is that in emergency medicine, we pull all these techniques from other specialties, but a lot of those things are not really as easy for us unless we're doing them every day. So the classic thing for cardiac tamponade is to check the blood pressure drop during inhalation and see if it drops 10 points. That's called pulsus paradoxus in the modern definition. But that is not something we normally do. We're not even taking manual blood pressures at all. And to do that in a very sick patient is something that I don't think is commonly done. There are other ways of identifying the same physiology. For example, pulse oximetry. If you see a waveform that's the amplitude of the plethysmography, if it's dropping during inhalation, that's a sign that this may be tamponade. And there's great articles in the literature where they post that and then they drain the patient and they show you what it looks like afterward. If you want normal or baseline, just put the pulse oximetry probe on yourself and see what that looks like, and then put it back on the patient. Of course, it's not the same person, but that will that can be a clue to see excessive respiratory variation in your patient. Another one is simply the original pulsus paradoxus. So Kussmaul in 1873 published on 3 patients that had their pulses disappear during inhalation. And so he wasn't actually checking the blood pressure drop of 10 points. He was actually feeling the pulse disappear. So if you feel their, say, radial pulse and it completely disappears, well, that's tamponade, and obviously it's a late stage. Maybe you feel the pulse noticeably weaken. That also can be helpful. At any rate, feeling the pulse is something that takes only a few seconds and is very familiar to us, so we should be doing that in these cases. And then the final thing is that increasingly echo is just becoming the norm for us. And so it actually is pretty easy to look for one of the classic findings on tamponade, in that we're not going to do things on echo that we don't normally do, but looking at the parasternal long axis is what we normally do. And so the only added step is clicking the M mode button. And that's where you get those lines, and you'll see 2 large black lines. One of them is the right ventricle, and one of them is the left ventricle. And the right ventricle is the one closer to the probe, of course. And so the question is there diastolic collapse in that right ventricle? And so the way you find diastole is actually really easy. You look at the left ventricle black line, and when the mitral valve opens, you see this notch upward. So you look at that notch upward, that's diastole, and then you look at the right ventricle and you just look for any signs of collapse at the same time, and that's early diastolic collapse. And if you see that, you can tell your cardiologist that you see tamponade. So hopefully that helps. In summary, it's a continuum and not a binary diagnosis, so just be aware of that. 2 was consider the triggers, hypotension plus effusion. And then 3 was use the tools that you're already good at, like looking at pulse oximetry, looking at the waveform, or checking the pulse yourself. And then finally, the echocardiogram.